I would like to welcome everyone today. We are here at the final session of our chronic kidney disease structured collaborative, and we really want to thank you for attending these different sessions every other week. We hope that it's been helpful to you, and today I think there's some more wonderful resources to discuss, and we have great presenters again for you today. Returning, of course, is Dr. Campbell. He will be talking at the end of our session today about diversity, equity, inclusion. But today we're going to be starting off with planning for the end-stage renal disease. And as you know, we don't want folks to get there, but unfortunately people do. So we will definitely want to talk about that, as you'll find out from Deborah, how important it is to have that discussion, and also Candace Coles. So as we always do, we will start off with, and I think that you have all, you've all chatted in, and I guess I missed that slide this week, but here's our objectives today. As you can see, we're going to talk about the options for patients if they end up getting to that end-stage renal disease. We're also going to be talking about a life plan. We're hearing that not everyone really understands what that is, where to find it, how to embark on this, and this is something very important for primary care. And then the end of the session today, we're going to definitely touch on how to comprehend the importance of diversity, equity, and inclusion in clinical and community care and support with Dr. Campbell. So let's begin by first having Deborah and Candace, if you'll please introduce yourselves.
Sure. My name is Debbie Bowe. I work for Midwest Kidney Network. I've been in renal for almost 50 years. Next year will be 50. So I've seen it from the very beginning to now where we're at, which is an amazing point. And yeah, I just really feel a lot of responsibility for educating patients and getting them to the point where they understand dialysis and that they are comfortable in what they've chosen.
Thank you. Candace?
Yeah. Hi, my name is Candy Coles. I'm the Quality Improvement Director at the Midwest Kidney Network. I have about 25 years working with the ESRD population, and that includes doing acute dialysis in the hospital setting, in-center dialysis in the outpatient setting, as well as home dialysis therapies, both peritoneal dialysis and HHD. I've also spent about 9 years working with Hennepin County transplant surgeons doing vascular access. So I worked in surgery, putting in fistulas, grafts, and PD catheters. And so I'm hoping to share a little bit of information on that as Deb goes through her presentation or her talk, and answer any questions that anybody might have.
Thank you for being here today. And as they mentioned, this is going to be a conversation. So the first thing, though, that we want to do is we want to launch a poll. And the first question, we'll have you answer. Let's see, answer both of them. I was thinking I had them out separate. I'm sorry I don't. So if you'll please start answering the first question and also the second question.
And the first question, meaning where it says crash into dialysis, it's ending up in the hospital and it's like all of a sudden you need to start dialysis yesterday. So that's what we refer to as crash into dialysis.
So we'll give it just a few more moments. If you're just joining us, please take the poll. We have 2 questions for you today. So we'll give it one more moment. Okay, we're going to end this poll. And here are the results, especially so Deborah can see. As you can see, 30% is the first answer, thinking that maybe that's how many patients go into dialysis. 50% or 75%. Deb will reveal the answer in just a moment. And then just so you can see, we have about 5 out of 8 discussing that they happen to know what life plans are. So now onward to the conversation with the partners at Midwest Kidney Network. Deborah.
Okay, thank you. What I'm going to talk about is patient perspectives, how they feel when they get that diagnosis and saying that you need dialysis yesterday. Kidney failure is like a personal tsunami. It just kind of knocks you off your feet. Patients don't want dialysis. They have strong emotions. Anger, depression, fear are very common. They fear a life that is not worth living, that they, there is a treatment, but is it something that I really want to do? Their diet is affected, what they can eat, what, like you were talking before about salt, all the medications I have to take. Can I still continue to work? Can I travel? So every aspect of a lifestyle is threatened by dialysis. And humans cannot learn when they're afraid. And that's generally the first emotion that they get is, oh my God, what is this? I can't do this. I don't know if I can do this. What we're trying to do with early education is to give them hope. And when they have hope, they have less anxiety, less depression, better mental functioning. If anyone is used to trying to teach a brand new patient or a patient with CKD in 4 and 5, anything, and you feel that you're repeating it over and over and over, they don't listen. I mean, they listen, but they don't understand. So until they have hope and until they feel a part of the process, it's all one big fear. What we're trying to do is get treatments that match their values, and that will give them hope. So there are free, fabulous tools that are out there that are on the internet that show the different types of dialysis, what you need to do home dialysis, PD, a preemptive transplant. There are all different ways to learn how to choose a modality and how to be a part of the choice. A lot of patients that do crash into dialysis end up in a hospital. The doctor puts a catheter in their neck and they start hemodialysis in the hospital, not knowing that they had a choice. They could have maybe done peritoneal dialysis and had a peritoneal catheter placed instead. A lot of times patients aren't consulted when they first crash in. It's like, we got to get you dialyzed quick. The quickest way is to put in a catheter and put you on hemodialysis. That's not necessarily the best answer. And if we knew the patient's wishes, and if they had had some education before, that they knew that they could pick home dialysis and they could pick peritoneal dialysis, that kind of, gives them part of the whole process. They get to understand what dialysis is and what is the best type of dialysis. There's 8 different modalities that they can choose. And there is a site on a website that shows the different values, what matters to you. I need to be able to work. I need to be able to go to school. I want to travel. I want to eat out and drink what I like. I love to swim and take tub baths. So that's someone that may not do peritoneal dialysis because the catheter comes out below the waist. And if you would swim, that would get wet and there would be a chance of infection. I want to feel well from one day to the next. Daily home hemo is pretty much like your own body. I mean, if you dialyze for a couple hours every day, all your waste products are removed. You don't have a big shift in chemicals and in water that you're taking off a patient. And they do feel better every day. They don't have that dialyze on Monday, don't feel good until Tuesday afternoon, Tuesday night, and then I have to go back Wednesday for my dialysis. So there's a lot of different things that they can look at to clarify their values. There are several different groups, but the one thing that I'm going to talk about is a life plan. And it came out of a multidisciplinary group that did vascular access. They wrote up a plan for how to get the correct access in the patient. And life plan includes the patient as number one. primary nephrologist, a primary interventionalist or surgeon that can put in a catheter, a PD catheter, or a fistula or graft, and the primary care practitioner. And the primary care practitioner is a huge part of this team because they see the patient first. They know the patient. They've had the patient as their own patient for maybe 1, 2, 3, 4, 5 years. When they go to a nephrologist for the first time, that nephrologist doesn't know that patient and doesn't know their background and how they live and what kind of family they have, kind of job they have, what their goals are. And that's what what the life plan is trying to find out. We're looking at different modality selection, but we're also looking at the patient goals. Do you want to travel? Do you want to continue to work? Do you want to be independent, or would you rather go into a dialysis unit and have the dialysis done for me and then I don't think about it for the other days? But there are so many different pieces to a life plan. And number one is to find out the patient goals, find out what they want to do. And then once we find out their goals, and the way there is one website that you answer like 6, 8, 10 questions, and then it gives you what option would be the best for you. So if you check all these different things and you want to feel good every day and you want a little bit more autonomy, you want to continue to work, home hemodialysis might be the best option for you. So that conversation needs to start at the primary care physician level. Just the idea that they need to see a nephrologist. Sometimes that jump to going to see a nephrologist is someone they don't want to see, because they know that once they see that nephrologist, they're that much closer to end-stage renal disease and needing dialysis. Whether it be home dialysis, peritoneal dialysis, or a preemptive transplant, which is something new that can be talked about also. But the primary care physician is a huge part of this team because they actually know the patient, and they're not as threatening, I think, as a nephrologist. Once they go to the nephrologist, it's like, and once I get that fistula, I'm getting closer. But they need to understand that it's important to do all of this ahead of time. So when you do need dialysis, you're not all of a sudden on Tuesday, you're in the hospital, and it's like, you should have started on Monday. So it's kind of taken out of their hands when they crash into the hospital. The physician is the one that kind of makes the call, put a catheter in, put them on dialysis in the hospital, and then send them to a outpatient unit. That might not be what the patient wants to do. If the patient wants to do PD, he could have had a preemptive catheter placed, and they bury them nowadays. That you can have the catheter placed 3, 4, 5 weeks ahead of when you need to start dialysis. But a lot of that stuff needs to be planned out. So it needs to start at the primary care physician level, then go to the nephrologist. And then from there, they go to this access person, whether it be interventional radiologist or a surgeon, to have the exact access that you need placed. So Candy, if you want to go through the different access pieces and what else they should be doing to prepare for dialysis.
Sorry about that. So there's a variety of access for dialysis patients, and education, pre-education by the primary care physician, and working collaboratively with the nephrologist, depending upon what the patient's choice is. After they look at their life plan, they get education on their access choices. And for peritoneal dialysis, it is a peritoneal dialysis catheter that's placed in the abdomen, that is done by a surgeon or a physician in an access center. It could be interventional radiology. Very important to make sure that whoever is going to put your access in, whether it's a fistula graft or PD catheter, is someone that has done this repeatedly. And you know that they have had a successful results with the patients that they're putting these accesses into. Because it isn't just simply putting in a PD catheter, it's making sure they're positioned correctly and that they're going to work for the patient when they get that first fill, when they go in for training. So between the primary care physician and the nephrologist, there's the discussion of, who would you recommend? Where do we refer this patient when they do make a decision on their access? PD catheters are usually placed laparoscopically. They can be done in interventional radiology, or they can also be done in a vascular access surgery department. They can be done open, or they can do, like I said, laparoscopically. That's up to the surgeon. More often than not, they're done by a lap procedure. All accesses are generally done as outpatients. You come in, you go to same day surgery, the access is put in and the patients are discharged home with directions. For hemodialysis, about 15 years ago, I would say most patients, if not half patients, received what we call bovine grafts. And then fistula first came out, and so bovine grafts kind of took a step into the background, and most people were given fistulas. Nowadays, there's a little bit more information coming out saying, let's make sure we're looking at what's best for the patient. If we know that patient does not have real good veins for a fistula or couldn't support a fistula, looking at discussing a graft placement isn't as taboo as it was once we had transitioned, about 15 years ago. So you might see your patients, they're going to be sent to a surgeon for that decision and that discussion. But with either a graft or a fistula, they'll go in, they'll have their surgery, and they're going to be sent home with directions for care. And a fistula usually takes about 6 weeks before you can utilize it. So when that patient is going to need dialysis, they're going to want that patient to be educated and get in to see a surgeon and get that fistula placed. There's some exercises that the patient will be given to do to build up that fistula. So when they do go to the dialysis center for dialysis, the team will have better luck cannulating it. A graft, on the other hand, can be used much more quickly. We usually used to recommend 2 weeks. So that's some consideration. And Dr. Campbell, you might want to comment on this as well. Do you see any difference nowadays with patients receiving maybe grafts rather than fistulas, or are you still seeing mostly fistulas?
Well, I'm not in the day-to-day practice now, but CMS got wise and started paying more for the fistula than the graft.
Yeah.
Wanted before for the surgeons to put in more AV fistulas, but they would pay less. So you get what you pay for. So I think now from a payments point of view, as well as the quality point of view, the fistulas are going to last longer. You don't get the infections you do with the graft. So yes, there is a positive trend. And now that the networks are heavily involved with projects to increase the percentage of AV fistulas, I think we're on the right track. One other thing I'd like to say that, most patients start dialysis with a catheter. Catheters carry risk of infection. You don't get as good dialysis. And when you look at patients with catheters, their albumins are not as robust as individuals with a graft or a fistula.
I agree. And the infection rate with catheters at times can be fatal. I think when we see patients who get a catheter because they've crashed in, unfortunately, there's not a lot of pain. Once that catheter is in, going in for dialysis, you hook up to that catheter. There's no needle sticks, there's no discomfort, there's no infiltration. So a lot of times the patient can develop a comfort level with that catheter, and trying to get them in to get a fistula placed or a different access place can be difficult and understandable. As Deb was talking about with the fear, if you're dealing with a lot of fear just being on dialysis, it's one area of control where a patient can make a decision and say, I'm really happy with this. So they need to be well educated on why a catheter is not the choice for a dialysis access. But again, like I said, I think working with the nephrologist collaboratively, being able to identify surgeons that have done a lot of access placements, whether it's PD, fistulas, or grafts, you want somebody who has a really good track record. Because sometimes, those accesses have problems. Fistulas may not work. They start at the wrist and move upward. That wrist fistula may not work. They may end up in the upper arm. So it might not just be one surgery. And as well as grafts also have their individual issues with clotting and revisions, as the same as fistulas. So it is frightening for the patient. And there are complications that can arise with those. So having a good surgeon who has done a lot of work placing accesses, who can have those discussions with patients, is really important. Do you have anything to add, Deb?
No, not really. I didn't know if there'd be any questions. The main thing our purpose of what we wanted to get across is that team collaboration,
Right.
starting with the primary care physician and the patient, and then nephrologist and on down. And part of the reason that we're really pushing early education and home dialysis and transplant is that in July of 2019, President Trump signed an executive order on advancing American kidney health. So he had wanted within 5 years, 80% of our patients either being on home dialysis or having a kidney transplant, which is a daunting task. We have goals every year that we're moving on up to trying to get to those numbers. But in order to get to those numbers, you need that education. And it comes back to that. So there are many, many sites that you can go to that list CKD education, that list actual choices that you can go through. There's a kidney school that's on the internet that you can look at. 25 different modules and like nutrition and bone health and all different dietitian, social work topics. So
Yeah.
there are, yes. Mhm.
Oh, I was just going to add one more thing about transplantation, but you
Okay.
I don't
No,
want to
no.
interrupt you. You can finish your thought there.
No, go ahead. I was just
Oh.
saying that there are just a lot of different sites that we can give to Mary that she can send out to everyone, that they can actually read the executive order and see a copy of what the kidney life plan looks like.
One of the things for patients that's very difficult is asking for someone to donate a kidney, a living a living donation. And we do at times see people getting preemptive transplants. And usually they've talked to their primary care physicians. Their primary care physicians know which direction their renal disease is heading. And in working with a nephrologist and the patient, there's a lot of resources out there, and Deb can share some of those as well as I, on how does one ask for a kidney. Most patients are not comfortable with this, whether it's their family, their church, and reaching out to friends. We have had patients in the past that have actually gone on Facebook and said, I need a kidney, and got an altruistic kidney donated to them and been very successful. Or through their church, it's surprising the number of people that will step forward, but it's still very hard for that patient to ask. So I think getting resources related to that into patients' hands, it's the best option for them. And if we can incorporate that into that primary care CKD transition to ESRD setting, that would be really beneficial to patients.
I just want to mention there's a real story out there that we should probably see if we can get that person to come on someday for Superior Health. But we have a colleague at the Wisconsin DHS. Her husband had a need of kidney transplant and couldn't find one. They actually brought it to Facebook. And so many of us who then found out about it shared it widely. and they ended up finding a kidney donor. Wasn't a match to him. However, kidney matched to someone else. And then since he brought that forward, it moved him in a different spot on the kidney transplant list. And he is now, I can happily say, he did get his transplant, and he is like 1 year post and doing really well, and actually back to work, back to normal life, normal as possible. So I'm glad you brought that up, Candy, because that's really a big deal people don't really think about.
Yeah.
Right.
And
like
you probably
said,
read about some of that too in the paper of the transplant chains.
mhm,
You know, if your family member doesn't match you and matches somebody else, and that somebody else's family member matches somebody else. And I think the largest has been 8, hasn't it? That it's gone across the country, that 8 different people got
Yeah.
transplanted on the same, because it was family member giving to someone else. And they call those transplant chains. And it's really kind of neat to see that and how that all, and can you imagine the amount of work that it takes to coordinate all of that? But
right.
it's a tremendous effort, and it's just a really great way of sharing. You know, if you're willing to give your kidney to your mother, but if you can give it to someone else, with someone else and someone else, your mother will eventually get a kidney from someone. It's
And
just really a neat thing.
those are some of the little tidbits too that we hope that we can kind of bring to light at these sessions, because I'm sure in primary care education, when you were being educated to be a primary care provider, I'm sure they didn't necessarily cover that area. And if they did, it was very, very tiny bit of time. And boy, how are you supposed to remember all that? So I think that's really good to know those things and not just leave that to, say, the ancillary support that you have, but having a little bit of that knowledge as well. Anyone on the call here want to open up? I know both, I know Abigail, you both talked a little bit about, you know, kind of how you're taking this forward, and curious a little bit about life plans. Have you incorporated that into your planning as you're kicking off your CKD project?
Yeah, we have. I think it really goes hand in hand with just overall advanced care planning, and we know that can be an area that's tricky for some providers to broach. So I think just providing educational resources around advanced care planning and enabling our care managers to start having conversations around that. I think that really goes hand in hand with how folks kind of perceive dialysis and what might be the right path for them. So yeah, but definitely education's needed.
Wonderful. Anyone else want to comment or ask a question? You have before you, you know, these great folks from Midwest Kidney Network along with Dr. Campbell. So please take this time and ask them some questions or run something past them.
While people are thinking, I just want to say that the crash and into dialysis is very real, because a lot of times trends are not being observed. It's really important that individuals trend their kidney function, and we empower patients to trend their kidney function. A number can either go up, down, or stay the same. And we know it's not going to go up. So if it's going down, we need to empower patients to ask, why is it going down? And to ask about the rate at which it's going down. So that's really, really important. And we need to reemphasize, you know, the no sticks in the non-dominant arm, no blood pressure in the non-dominant arm, to ensure that individuals are preparing that are near the end. And if they're between 15 and 29, we need to really refer them for transplant evaluation. But too often we're waiting until they're, you know, below 20 or 13 or 15. And by that time, they're under the gun. There is a significant wait time. And again, I cannot emphasize enough and agree with the presenter so far how going to social media, going to church as a forum to find and a potential donor. Again, I have had someone who's had a transplant from a bowling buddy that it's just a random topic that came up, and the bowling buddy was a match.
So we have a comment, and thank you, Dr. Campbell. Tammy Becker is sharing, agree with the education of care managers and how to approach in-life plans for patients. I had a parent who crashed into dialysis and how it blew my parents out of the water and starting dialysis. I mean, I feel for you, Tammy, that I can't even begin to put myself in their shoes, in your shoes. It is a lot. And I, as a social worker, didn't know a lot of this about chronic kidney disease and planning for stage 4 and 5 prior to starting to work with these folks. So it is enlightening and helpful, and much appreciated. Anyone else want to chat in some questions or comments? Please do. We're just going to move forward and have Dr. Campbell jump into, sorry, I'm jumping too far, into the diversity, equity, inclusion, not to be forgotten, into our practice. So we'll hand it over to you, Dr. Campbell, and thank you, Deborah and Candy, for doing what you did today. And we'll hear some more questions in a bit, but feel free to put in your questions for Candace and Deborah in the chat as Dr. Campbell gets started.
Okay, thank you very much, Mary. Diversity, equity, and inclusion. It's very important to keep in mind that when it comes to transplantation and dialysis, people of color wait longer. They are less likely to be referred, and they're less likely to have a home modality. So, and they're less likely to be offered the opportunity of transplant and to assume a home modality, or even nocturnal, which is, it's an alternative these days to dialyze overnight. And individuals who dialyze overnight, as a matter of fact, they have less phosphate issues. The majority of them, if not all of them, are not on phosphate binders. Well, let's look at understanding the why of healthcare disparities. You can see the various categories. I love this slide because it breaks it down category by category. Economic stability impacts our outcome. If you're not employed, you're less likely to have private insurance. And if you're in debt, again, you're unlikely to be able to afford co-pays, and if you're underinsured and uninsured, you're unlikely to be able to take care of your medical expenses. Now, I've coined a phrase that says, I can no longer participate in anything that uses the currency of diversity to purchase the goods of inequity. And I want you to understand what that means. A lot of individuals will actually champion diversity, but have no intention of having equity being served. In other words, the currency of diversity is being used for the sleight of hand of inequity. They have no intention. So I no longer participate in those activities or with organizations when it comes to DE&I that use the smoke and mirrors of diversity when they have no intention of equity. Employment is one of those areas where we said, oh, we have diversity of team members, but then we don't have diversity in pay. And there's no secret about the inequities of pay between males and females, women and men. That also impacts care. Also, if you go over to the far right, the healthcare system, the coverage is different. You're going to get a difference in healthcare if you have Medicaid versus Medicare versus a private plan. Your access to certain networks are going to be limited. because of that. Also, minority physicians actually take care of the majority of underinsured and uninsured in this country, but yet they have to fight to be a part of private pay networks or just being a part of the network. I remember when I was in private practice in the north side of the city, there was only one group on the panel, and they said, well, we have enough doctors. That group has 30, so we don't need any more nephrologists. But I said, you're all in the same group. And I don't think there were any minority physicians in that group. So I had to go to fight to be a part of that group, and eventually was successful. So if someone wants to have a doc that looks like themselves, it becomes increasingly difficult because those docs cannot be a part of that network. Also, the neighborhood environment and the physical environment of that neighborhood actually impacts the outcomes in health. If I live in a home that's not air conditioned or heated or filled with lead pipes, guess what? My kids are going to have poor outcomes. I'm going to have poor outcomes. And when you talk about air conditioning and heating, that impacts the elderly more. So again, that is an issue. Literacy, education, language barriers, those are obvious how they impact the outcomes. Food security, or I should say insecurity, impacts health outcomes. Not having access to healthy options can really impact diabetics and hypertensive patients and even the elderly. Also, the community and social context, stress, exposure to violence and trauma. All right, going back to pharmacy deserts under neighborhood issues. If you live in a pharmacy desert and you don't have transportation to go outside your neighborhood, you can see why filling your medication can be a challenge if you don't have delivery services. Next slide, please. Health insurance coverage is also a major driver for health disparities. People of color face longstanding disparities in health coverage. If you look at this very busy diagram that spans from 2010 to 2019, although overall lower number of individuals actually are underinsured and uninsured, but still, when you go from top to bottom, you look at people of color in every category, whether it's Hispanic, Native Hawaiians, and other Pacific Islanders, Alaska Natives. As you go down and compare each category, Blacks, when you compare them to whites and Asians at the very bottom of the graph, you'll see that there's a big gap in coverage. If you look at Hispanics, for example, 20% of Hispanics have poor insurance coverage on their uninsured versus 7.2% of Asians, 7.8% of whites. Next slide, please. Life expectancy is tied to outcomes and income. If you look at the poorest fifth to the very far left of the diagram, compared to the richest fifth, Americans to the far right, you will see that you have a greater life expectancy. You're going to live longer, the more income. When you look at some cities, for example, I think it may have been Denver, Colorado, I looked at, when your income is less than $50,000 per year, you're more likely to have diabetes and hypertension than if you make above $50,000. Next slide, please. What can be done? Call to action. Again, if we're really serious about outcomes, health outcomes, or progress involving diversity, equity, and inclusion, we can't use diversity as a currency to purchase inequity. If we're truly serious, we have to accept the ugly truth of the significant extent of the healthcare disparities and to decide, do we really want to make healthcare equitable? Do we really want equity? If we do, yes, we do have to have a diverse healthcare staff that can relate to patient and act from social, cultural, and economic and religious standpoints to help deliver timely and culturally competent healthcare. Yes, we do have to learn about cultural and emotional intelligence to be able to adequately deal with a melting pot, which America has become. We do need DEI champions in facilities to ensure that DE&I issues are addressed at the table in our CQI meetings. We also need to have champions in other areas. The clinics that tend to have champions in vascular access tend to have better outcomes in terms of having higher fistula rates, lower catheter rates. Also, we need to reduce the number of uninsured and underinsured Americans among people of color and to improve the access of that care and to ensure that when they do access care, that the quality of care is, there's equity in that access to care. We do need to reduce the number and extent of food and pharmacy desert. We do need to have a robust community education programs involving and regarding social and health resources. And again, without economic equity, it doesn't matter if you have diversity, if there's no equity in what you're doing, including economics, including homes, the community, the resilience of those communities based on equity will determine outcomes as well. Next slide. And we'll go to our discussion segment.
So everyone, this is a great opportunity here to either share where you're going with your own work towards diversity, equity, inclusion. Do you have a DEI champion already, or are you looking to build up someone's background in order to include that? Tell us a little bit more about your organization. Or you can also ask some questions at this time of either Candace or Deborah, or of each other. This is sort of our big finish, you know, of the 6 sessions. And feel free to bring up any questions you may have from the past sessions as well, or impressions. I don't know if Abigail would like to share a little bit more about their planning. We would enjoy hearing a little bit more about your kicking off your CKD program.
Sure. Abby, do you want me to go or do you want to share?
Yeah, you can go first and I'll add some color.
Okay. So we, our organization is running a REACH ACO. And so we're working with Medicare fee-for-service patients. And we've got about 15,000 attributed lives. And so if you think about CKD being, 15% of that population, probably somewhere around 2,500 patients. When we look at our data, it seems to be underdiagnosed. And then we've also been able to see that for patients with stage 3B and 4 kidney disease, their monthly spend is above what our benchmark is. And we also see that we have, excess spend in our ESRD population. Our partner health centers have high rates of minority patients, as well as dual eligibles. So, this is the same patients that Dr. Kimball was just talking about who have poor outcomes. And so we're really wanting to make the case to our health centers, and we think we've got a good story that we can be successful financially and also help reduce disparities at the same time by focusing on CKD. And so we have a kind of 3-part approach to our first phase, which is we identified patients who are in stage 3B and 4 for them to outreach through the care managers that we have embedded in the practices, and make sure that they get in with their primary care provider, get to nephrology if needed, get follow-up labs, and just kind of get the ball rolling. And then we've Abby actually created a pathway for the care managers to use, and we're kind of converting that also to a 1-pager for providers, just to really synthesize as succinctly as possible all the different things that they should be doing for the different stages of kidney disease in their population. And then we've provided them some continuing education resources as well to kind of improve their skill level with managing CKD. We have a care management platform that we will be building this module into, but first it's kind of just pen and paper just to kind of work out the kinks and see if there's any modifications we need to use. And then we'll also be incorporating GFR and albumin lab results from our health centers, mixing that with the claims to really hone in on those patients that need more attention. So that's kind of our approach and our kind of first round of what we're focused on.
And it's so important to include Z codes in what we're doing, because Z codes will give the payers, whether Medicare or private payers or Medicaid, the lay of our land. It will give them a eagle eyes view into the terrain in which we're operating. So that's important. Also, when we have pushback from our payers, we need to remind them that ESRD is the single most expensive diagnosis for Medicare. They consume a lot of the most resources of any Medicare population as well. And life expectancy is so much lower. An average person is going to live 6 years on dialysis. That's it, 6 years. Most of them will die rather than get a transplant. So that's why living-related donor issues has to come to the forefront in our plans. And then if they're between 70 and 74, when they start dialysis, they'll most likely die in less than 4 years. So that's another reality now. We need to emphasize with our older patients over 65 that we really need to prioritize them to ensure that they're transplanted rather than just going on a waiting list, and they most likely will not outlive the wait period.
Thank you for those additions, Dr. Campbell. Abigail Sibley, did you have anything to add to what your colleague has shared?
No, I think Abby really covered kind of what our approach is. And again, really trying to enable our care managers as part of, really comprehensive team-based care to support the providers and kind of a checks and balances to make sure that best practices are ongoing in these different stages of CKD. And it is interesting, as we have learned, a lot of these health centers, I think, well, pretty much all of them, if not most, don't really have an approach when it comes to managing CKD and ESRD patients. I think it's a population that kind of freaks people out because they don't really know what the right things are to do, and it's complicated. So I think that just kind of giving them the toolkit to better manage these patients is hopefully going to show us, not just a cost return, but most importantly, better outcomes.
And again, to emphasize, it's important that there's a DEI champion. For example, in Nashville, there is a burgeoning population in regards to Vietnamese, Iranian, and Egyptian. And so interpreters, cultural approaches to transplantation is going to be different in many cultures. And then also individuals who are of the Jehovah's Witness religious affiliation, that population you have to manage very differently, especially when it comes to anemia as well as a solid organ transplantation. So we have to consider religious issues, we have to consider race and ethnicity, and when we're including that, language barriers.
Anyone else have something to add? We have just a couple minutes left. I'm also throwing in the chat our survey for today. If you would please complete that, that's really helpful for us. Really pay attention to the fact if there's something more you'd like us to talk about in the future or more resources to send to you, please feel free to put that in the area where you can add things. Pause for a moment. Anything, there's nothing currently otherwise in the chat. Well, with that, we will thank you all, first of all, for attending these 6 sessions. Many of you came every single time and contributed, and that was wonderful. It's great for us to collaborate with you and learn from you as well. We're excited to hear about the CKD kickoff, and I'll be reaching out to you both to hear a little bit more about that and see if there's anything else that we could do for you with that. And thank you to our speakers today, Deborah and Candace, and a extra big thank you to Dr. Campbell, simply because he has been our key presenter for multiple sessions. All of it has been really helpful. And I think we could talk for session after session about many of the areas. So share this recording that you'll be getting from us with your colleagues, and feel free to reach out for more information. We will send you the information that Deborah spoke about in the next week. Any other last questions or asks from the group? All right. Well, thank you so much, everyone. We'll end the session and look for this to possibly repeat it in the fall if you want to send more colleagues to this collaborative. And don't forget to complete the survey. Thank you so much. Bye-bye.
Thank you.
Thanks, everybody.